Oncologic outcomes of robotic left pancreatectomy for pancreatic adenocarcinoma, a single-center comparison to laparoscopic resection. Surgical resection in pancreatic adenocarcinoma is presently the only treatment option with possibility for long-term survival or cure. In the late 1990s, the first laparoscopic approach was attempted for benign disease in Scotland. Since then, attempts to master this minimally invasive option have ensued. However, resection is a demanding procedure requiring considerable expertise and technical complexity that may be magnified in a laparoscopic setting. If technically apt, however, a laparoscopic technique is safe and suggests similar, if not improved, perioperative and long-term outcomes in comparison to open surgery. With the development and recent upsurge of robotic surgery, the robotic left has now taken to the forefront of minimally invasive pancreatic surgery. First performed in the early 2000s, it is becoming more popular due to the advantages it offers. Overcoming laparoscopic limitations, robotics offers optical magnification, 3D depth perception, augmented instrument articulation, and suture targeting precision. Robotic left pancreatectomy suggests outcome equivalence and often even advantage over laparoscopic. Studies show shorter lengths of stay, reduced conversion rates, and decreased morbidity. Studies have also suggested oncologic benefit due to improved lymph node harvest. Long-term oncologic outcomes, however, have not been thoroughly investigated, with a few studies published suggesting equivalent results. This study aims to investigate the perioperative and long-term oncologic outcomes between robotic and laparoscopic approaches in pancreatic adenocarcinoma at a high-volume hepatobiliary center. A retrospective review of all patients who underwent minimally invasive lefts was performed over a 10-year period. Chart abstraction was used to record the listed variables. 75 minimally invasive lefts were identified from a prospectively maintained database. 33 of the cases were robotic and 42 were laparoscopic. There were no differences in gender, age, BMI, use and regimen of neoadjuvant or adjuvant chemotherapy between cohorts. Conversion rates to open were similar for both, with only one case converted in each cohort. There were no differences in estimated blood loss, but operative time was significantly longer in robotic cases. There was a significantly higher lymph node yield in robotics, with a median of 20 nodes collected versus 12. There were no differences in length of stay, postoperative minor or major complications, 30 or 90-day readmission, or 90-day mortality. There were no difference in tumor size between cohorts. The robotics cohort had a slightly higher rate of R0 resections. There was also a trend towards improved median overall survival in the robotics cohort. Additionally, there was a trend towards a longer time to recurrence and decreased recurrence rates. Limitations of the study included case distribution by time period. Half of all the cases were performed between 2009 and 2015, and half between 2015 and 2019. 60% of laparoscopic cases were done in the earlier period versus 40% of the robotics, which can influence oncologic outcomes. The sample size of the study is small, and the analysis is subject to type 2 error. Additionally, this is a retrospective study susceptible to selection and recall bias. This study demonstrated the perioperative and long-term results of robotic and laparoscopic techniques in pancreatic adenocarcinoma. The intraoperative analysis demonstrated that while robotics had a longer operative time, there was no difference in EBL. Postoperatively, complication rates were similar according to Clevey and Dindo grading, and there were equivalent pancreatic leak rates. There were no differences in readmission or 90-day mortality. In regards to oncologic outcomes, the robotic cohort had a significantly higher lymph node yield and trended towards improved oncologic outcomes such as R0 resection rate, recurrence rate, and survival. Statistical significance was not achieved, which may be due to the small sample size and type 2 error. The higher lymph node yield may be secondary to the type of dissection performed, as the robotic approach allows surgeons to perform a radical antegrade modular pancreatosplenectomy, RAMP procedure. As described prior, these minimally invasive dissections are already complex, and ramps, an even more aggressive dissection, is not always technically feasible laparoscopically, and thus not performed for the laparoscopic resection. Alternatively, the advanced ergonomics and mechanical advances of robotics that overcome such laparoscopic limitations allows a modified ramp completion for each robotics case. This ability further may be reflected in the trend towards improved survival and longer time to recurrence in the robotics cohort. The decision to employ specific minimally invasive approaches remains selective and infrequently protocolized. At this study center, regardless of case difficulty, there is no effort to streamline uncomplicated or easier cases to the robotics pathways. All patient referrals are arbitrary, with only half of the surgeons offering the robotics approach. Regardless, Randomized prospective trials are necessary to suitably evaluate technique with limited bias. Additionally, a consistent criticism of applying a robotics approach is cost effectiveness. Although the study did not evaluate the difference in cost, postoperative advantages such as length of stay and complication rate seen with a robotic approach can actually result in significant cost savings when compared to conventional laparotomy. And in comparison to laparoscopics, robotics has been demonstrated to have comparable costs. This retrospective analysis suggests that robotic left pancreatectomy is at least equivalent to laparoscopic left in perioperative and oncologic outcomes. The improved lymph node yield in robotics may suggest actual oncologic benefit as advances in robotics allow surgeons to perform a more meticulous and aggressive dissection. Randomized controlled studies are needed to fully clarify oncologic benefits. Thank you very much.